Clinical Signs and Symptoms Alert. That is a working document. We encourage you to take this home, use it, disseminate it, get it out. It's going to be spoken to a little bit more about this. Without further ado, I'd like to welcome Jennifer Brown. She's a PhD with the New York City Department of Health, and we all know about the great advances in New York City about colorectal cancer and the screening programs. It was one of the things that inspired me to get into colorectal cancer public health. Come and tell us about the experience.
Thank you. How do I advance the slides?
Right here.
This one? Just press the green.
Yep.
Okay, good. Thanks very much.
And that's a pointer if you want.
Okay, thank you. Thanks to Cindy and Tom for inviting me. I'm going to skip the outline in the interest of time. That colorectal cancer is increasing among the young, has even been in the New York Times. And what I'm going to talk about today is a little bit on the New York City picture for colorectal cancer locally. So first, in New York City, a joint point analysis indicates that colorectal cancer incidence is declining for ages 65 and older, and that's the top purple line, by 4% annually. And this is from 2003 to 2015. And among ages 50 to 64, decreasing by 1.6% annually. But you can see on the lines that are further down, these are younger and younger cohorts, that it's either not declining at all or it's increasing. And I blew this up a little bit in the next scale. Among ages 20 to 49, colorectal cancer incidence decreased non-significantly up through 1990, and then from 1990 to 2015, the rates increased in New York City significantly with a percent change of 1.5 annually. When we break this down into white or black New Yorkers, we find that among white adults ages 20 to 49, the rates increased significantly with a 0.5% annual change. Whereas for black New Yorkers, the same age group, the colorectal cancer rates increased from 1993 to 2015 with an APC of 2.2, so 2.2% annually. So these findings emphasize the value of local registry data to understand our trends locally and the importance of timely screening, like we were just talking about, the need for clinicians to consider the colorectal cancer among those with compatible signs and symptoms. So we see that in New York City, the age-adjusted colorectal cancer death rate per 100,000 has decreased from about 21 to about 13.9 from 2003 to 2016. And over that same time period, colorectal cancer screening by timely colonoscopy, meaning a colonoscopy within the past 10 years, has increased from 41.7% up to 69.9%. Screening may have contributed to some of the decline we see in the mortality of the condition. However, colorectal cancer screening coverage does not extend to all of the target population. 45 is the ACS recommended age to begin. And I'd like to just share that in New York City, 71.7% of New York City adults ages 45 to 49 had not had a colonoscopy within the past 10 years, according to our New York City Community Health Survey. So about 28.3% of people in that age group are having colonoscopy, which may be surprising to some. But when you get to ages 50 to 74, 31% still have not had a colonoscopy within the past 10 years. And 75 years and older, 29% have not had a colonoscopy. And you need to, of course, consider that some of those people won't be eligible due to comorbidities or things like that. But if we want to improve the screening coverage overall, and especially at the younger ages, we're going to need a change in practice. So the New York City Department of Health has experience in changing direction in public health. For example, recommending colonoscopy first for colorectal cancer screening in 2003. This was prompted by a combination of recommendations for healthcare providers, healthcare provider tools, public health detailing programs for primary care, and colon cancer prevention, public education, and media. So just sharing some of the methods we use to make a public health change. The health department publishes a city health information bulletin that goes out to all primary care doctors in the city. This one is the example from colorectal cancer that we sent out in 2003 and 2009. and we're currently reviewing the recommendations of this to incorporate the most recent data on early onset. This document was followed by a direct referral form, and the direct referral form for screening colonoscopy was created by C5 and the health department. Using this form, your primary care provider could refer for colonoscopy without having to have the GI consult first. Another way to reach primary care is with public health detailing, and this allows about 9 to 12 months for development of a campaign at the health department. We train knowledgeable and persuasive staff on disease content knowledge, on selling, and on communication skills. Then we run a 12 to 20-week campaign, and the target is more than 2 visits for each practice. We sell key recommendations in a sense and offer supporting campaign materials. And examples of what are in a typical kit that we develop are tools for clinicians, resources, patient education, and all this is developed with best practices, including expert interviews, research into other existing campaigns, provider interviews, and consumer focus groups as well. In prior colorectal cancer campaigns, our recommendations for change have been to refer patients ages 50 with a family history for colonoscopy. That was in 2004 and 2006, that colonoscopy was the recommended method. And then in 2008, refer people ages 50 or patients ages 40 with a family history for colonoscopy, and to directly refer patients for colonoscopy rather than going to the GI consult. And this tabulates some of the reach of the public health detailing programs. So we went into specific neighborhoods where we thought there was a need and reached about 200 sites with each campaign. Our provider contacts were around 500 for each campaign, and then provider and staff contacts, because we don't just target the primary care provider themselves, but also their staff, were between 900 and 1,400. And our contacts per site were good, about 5 to 8 for each of the individual campaign. And then we measure whether their practices change with regard to the key things we were trying to have them change. And our data suggests that the public health detailing can be effective, that the recommendations to providers that we make and through public health detailing and other means can create practice change. You can see here that in the 2004 campaign, colonoscopy recommendations did increase significantly. In the 2006 campaign, colonoscopy again increased while FOBT use decreased, as we were recommending colonoscopy first at that time. And then in the 2008 campaign, use of colonoscopy remained high and use of the direct referral form increased. Some examples of the kind of materials we develop include comic book style pamphlet we've made for patients, Sandra's Story, Preparing for Colonoscopy. We've sent out 12,000 of these so far across New York City to primary care offices and GI offices, and to people who are in nonprofits who've asked us to send them 100 or 2 to distribute. And we have it now in 14 languages, available on the website or by request. They're free, so if you ask for them, we will send them to you. We also do a health bulletin, which is like a little pamphlet that we're recreating this year because of all the new data. And then we run media campaigns. For example, this year in 2019, we had a Detect and Prevent campaign, and we target these to New York City neighborhoods where mortality is high, and then place them in bus shelters, in the ferries, in the newspapers. We make radio announcements and include them for social media sharing. We translate them into a variety of different languages, and in next month we're going to have an Asian-specific campaign, because we found that screening by colonoscopy was somewhat lower in Asians in New York City. In summary, the number of new cases each year for colorectal cancer is only declining for those ages 50 and older. It's increasing in New York City for those aged 20 to 49, similar to what's seen nationally. The yearly deaths from CRC did decline as screening increased, which makes us hopeful that screening as a younger age, as a practice change, will make sense. And We find that change in public health practices, such as we're going to need for this change, may be facilitated by recommendations to providers with tools, with public health detailing, as well as with public education and media. Thank you.